Awesome. So we got that. Hi, Mark. So glad to see you. Okay. So we are going to get started. I'm not going to keep my meeting chat box open because I'll have so many different screens and then I get confused. I can be tech challenged on occasion. So let's just go ahead and jump into it. At the end, when we're doing questions, I'll come back to the chat so I can see if anybody typed in a question. Dr. LeBeau, I did get your question, so I will be addressing that today. All right. No problem, Dina. I'm going to be sending out a recording of this. So if you have to leave early, probably later tonight, you will get the link to watch the replay. Okay. Cool, cool, cool. So let me minimize this. Okay. All right, everybody. I am Dr. Cadet. I'm super excited to be doing this webinar with you all today. We are talking about work restrictions that work. So a lot of you are here today because you saw my LinkedIn post, or maybe I have you on my email list. So the book, oh, here we go with the text. See, I try to be so fancy, y'all. Is it showing up? It's not even showing up. Oh my gosh, why? Well, I'm holding up. Oh, wait, there it goes. Okay. So here's a copy of the book, Work Restrictions That Work. And it's a beginner's guide to writing work restrictions. And I first started learning about work restrictions and occupational health when I was a flight surgeon in the US Air Force. And that has got to be one of the most amazing jobs that I've ever had. And even though my title was a flight surgeon, it's actually a misnomer because I was not a surgeon. I was not in airplanes cutting on people. I was actually a primary care provider for aircrew. So that could be pilots, navigators, load masters. I'd not only take care of the pilot, but I'd also take care of his family members. So I was the family doc and the OC doc all wrapped into one. And every week we had a meeting called FOMWIG, which is the Flight and Operational Medical Working Group, something like that. And the goal was to look at all the flyers that were on our base, and there were 900 of them, and see why they were on DNIF status. And DNIF is duties not to include flying. So we would go through that list every week without fail. And our mandate from the government was that no more than 7% of our flyers could be down at any one time. And so each week in this working group meeting, the goal was, what does this flyer need to go back on flight status? So it wasn't a matter of, oh, we're just going to let him sit and be on DNIF status forever, not doing anything. The mentality was, what do we need to do? What do we need to do? We need to get him healthy. We need to get him back up in the air because we have a mission to fly, fight, and win. So that mentality was ingrained in me as a baby OCDOC. And now as an old or full-grown OCDOC, it's something that I've never gotten away from. So transitioning to the civilian side of things, I noticed a lot of practitioners don't have that mindset. And so when a patient comes in and they have a work injury and we give them work restrictions, we'll just let the work restrictions stay forever, or we'll never change them, or we'll just do whatever the patient tells us that they want to do. And that's actually not the right way to do work restrictions. So that's the motivation behind the book, is because I wanted to share with practitioners who maybe didn't learn this in their training what the right way to do and manage work restrictions is. And I also wanted to have a resource for the new baby OCDOCs, or maybe non-OCDOCs who need some type of templated system and methodology for writing work restrictions. So that's my intro. We're going to jump right into it. Work restrictions, the purpose is to tell the employer or the supervisor what the employee can't do. So a good example of this is no driving the semi-truck. Very clear, right? Supervisor can't mess that up. Don't drive the semi-truck. A bad example is don't plantar flex the right foot. Well, why is the bad example a bad example? It's because a supervisor who is reading the work status report or the work restrictions, they have no idea what plantar flex means. So you cannot use medical jargon on a work restriction form because it's going to make it difficult for the supervisor, AKA the employer, to implement what you've said. Okay. Now, this is a table from OSHA of permissible exposure limits for different chemicals. So if your eyes are glazing over at this moment, I apologize. And we're not going to dive deep into this chart, but I've underlined silica, which is a dust that you can breathe in, right? A lot of construction workers work with silica. And the provider to my left on red says no exposure to more than zero point 0.1 milligrams per meter cubed of silica. Now, I have seen providers write this on a work restriction note. Can you imagine the supervisor reading this? They're not going to have any idea what you're talking about. And then that decreases your effectiveness and it interferes with trust. Like, who is this person? Are they even a good provider? Because they're not communicating with us well. Okay, this is not the ideal restriction. Something that's better to write is no use of silica without appropriate respirator, right? So this is a very clear and actionable step that the supervisor can take. Hey, I just got to make sure all my guys have on a respirator, which is something that should be a part of their safety training anyway. If you write no exposure to more than 0.1 milligrams per meter cubed of silica, what do you want the supervisor to do? Do you want him to go hire an industrial hygienist to take air samples to make sure that they're not going to do that. So you want to make it as simple and actionable as possible. Okay. So restrictions are not designed to tell the to tell the employer or the supervisor what jobs the employee can do. You're only supposed to be telling them what the person can't do. Why? Well, the supervisor knows what light duty tasks can be made available to the worker. You don't know that. That's why it's not appropriate for you to tell the supervisor what the worker can do because your recommendations may not align with what the supervisor has available. So you wouldn't say something like Daquan can work with Excel spreadsheets. You don't know what type of computer equipment or programs the supervisor has. Now, Excel is everywhere, granted, but still you don't know what is available in the work environment. Same thing with Kathy can send faxes. You don't know if the fax machine in Kathy's area is in working condition. David can work with Jackhammer. You don't know if the supervisor has that piece of equipment. And even if you do know, again, it is not your job to tell the supervisor what the employee can do. You make a recommendation about what the worker can't do. Now, you can tell the supervisor what the employee can do in regards to medical equipment, right? So Susie must keep the wound clean, dry, and covered. That's okay. Bob must wear a medical boot. Perfect. Chantel must use crutches. All of those are appropriate because you're talking about medical equipment. Okay. Now, you can also tell the supervisor what the employee can do regarding their body positioning. So seated work only, perfect. Limit the standing to 15 minutes per hour. Must keep right leg elevated. So body positioning, medical equipment, you can tell the supervisor what the employee can do. But in terms of other activities, no, it is just what they can't do. Right? So we're going to go through some examples from head to toe. If you're taking notes, great. If not, I've listed out these examples in the book along with some templates that you can use to reference. So we're going to start with the scalp. If somebody has a laceration to the scalp, you want to say or ask yourself, well, do they have a headache? What other symptoms do they have? Have they had a concussion in addition to this laceration? What type of job do they have? If they're a fitness instructor and they have to jump up and down and lift heavy objects, you might want to give some tighter work restrictions. If they're a construction worker, right, you might want to say avoid use of head covering because you don't want additional pressure on the wound. If the person has had a concussion, then appropriate restrictions would be things like limit their computer use to 30 minutes per day, avoid complex mental tasks, don't work on slippery surfaces, allow 10-minute breaks for every hour of work. What you don't want to do is cocoon therapy, right? Or we're going to lock them in a dark room, put shades on them, turn off all audio and visual cues. No reading, no homework, no computers, no phone, no email, no texting, no social media, no TV. No, you don't need to be that strict with it. Now, it was originally thought that cocoon therapy was actually beneficial for concussion patients. It would reduce the demands on the brain, but we have found that that's actually not the case. And a gradual return to regular duties, regular activities, taking a walk, those types of things are really good for concussion. So moving on to the shoulder. Again, you want to consider what is their job tasks and how would those tasks impact the shoulder, and then just do the opposite, right? Don't do those things. So for the shoulder, you might say something like no overhead lifting, no overhead work, no push, pull, carry, lift more than a certain amount of weight. And the amount of weight is completely based on your clinical judgment. But it starts with you asking the employee, so tell me about what you do for work. Do you have to lift heavy objects? If they say to you, no, I'm a secretary, I don't lift heavy, then you giving a lift restriction doesn't make any sense and it's not helpful for the supervisor. So the restrictions need to go hand in hand with what the job duties are. Okay, so here's another example for the upper extremity. Maybe you want to say, don't use your left hand. Don't forcefully grip or grasp. I've had some folks who work in a lab and they're constantly pipetting and working that thumb and gripping the pipette. They get tendonitis in the wrist. That would be a great time to say, don't use that hand, rest it, right? Maybe you want them to wear a wrist brace, which is the medical equipment. Maybe they need an arm sling. So you would put that on the work restriction form. Okay, back. You probably, if you're an OCMED practitioner, see a billion back strains a day. So you'd want to say things like don't lift, push, pull, carry more than a certain amount of weight. Maybe they need to do mostly seated work. Maybe they need to be able to sit and stand and change position at will. Maybe you want to limit the amount of sitting that they do because that aggravates their back. So you want to be specific and say, well, hey, I don't want you to sit for more than 4 hours of an 8-hour shift, something like that. No repetitive stooping or bending, no crawling, no going up ladders. So again, if someone is a construction worker and they have a back injury, do you want them going up and down a ladder? Do you want them bending over and using a jackhammer? So whatever the job description says they have to be able to do, you want to write work restrictions that would say, don't do those specific activities. All right. And then for the lower extremities, maybe someone has an ankle sprain. So you're going to say no standing for more than X hours per shift, right? Seated work only or seated work mostly. Like if I'm a secretary, I can get up with an ankle sprain and go check the fax machine. But most of the time, I need to be seated in my chair. If I'm a nurse on the floor, I need to be seated work mostly. I can't be up and about taking care of patients. Do you want them to elevate the leg? Do you want them not to use stairs? Maybe they're a police officer and you don't want them to run. If they fractured their foot, they need to be wearing a moon boot to avoid putting direct pressure on the fracture. Maybe they need crutches. So these are all appropriate work restrictions that you could write for the lower extremity. And then wrapping it up with wounds to the skin. So if someone has a wound on their hand, right, you would say no use of that body part, especially if it's a very deep wound or it's in an area where there's a lot of contact that would be happening. You want to keep the wound clean, dry, and covered. Maybe they're getting a rash because they're a healthcare worker and they wash their hands multiple times per shift. You would say no use of X soap if that's what's causing an allergic reaction, or maybe it's the hand sanitizer. We've gotten away from latex and gloves in the hospital setting, but we've replaced that with a substance called nitrile. And you can have allergic reactions to nitrile. So maybe you need to limit the type of gloves that are used in the nitrile. And a lot of times it's the additives that are being added to the material to make it rubbery and resistant to liquids that make it allergic for folks. Avoid excessive hand washing, or maybe you want them to limit the hand washing to a certain number of times per hour. I had a respiratory therapist who told me he washed his hands up to 60 times an hour. And I thought, wow, that is a lot. So you would limit that if that's causing some type of contact or irritant dermatitis. Right. And then general, maybe you want to limit the number of hours that they can work during their shift. Maybe you don't want them working with combative patients. I've had a number of school teachers who have combative students. A lot of them have some type of emotional dysregulation, but maybe you need to take a break from that for a little bit. Or maybe you work in a certain classroom that's flooded and now the carpet has mold, and every time you walk in there, you start hacking up a lung. You could say no work in X location. Okay. All right. So that was just a general overview of the type of restrictions that you could write. There are so many different variations to the work restrictions, it's going to be impossible to list them all out. But in the book, we kind of start with a framework of how no matter what the situation, no matter what the job, no matter what the body part, you would be able to come up with an appropriate restriction. So let's look at a few cases just to put this into practice. We have a 22-year-old female animal shelter attendant who came in for multiple dog bites to the upper extremities. So, diagnosis, dog bites, or lacerations to the upper extremities. And that type of injury should take 1 to 3 weeks to recover from. It is super, super important to understand how long it should take to get over something so that you don't go into the encounter and write these open-ended restrictions that go on for years. You go in with a plan, and for lacerations, dog bites, that should be fully resolved within 1 to 3 weeks. So an appropriate restriction would be no lifting, pulling, pushing, or carrying more than 5 pounds, right? Now, if I put a 5-pound restriction on this, I am inadvertently telling the supervisor she can't work with heavy dogs. She can't be around the bulldog. She can't be with the Doberman Pinscher, right? Alternatively, you could write no work with animals. But if you write no work with animals, recognize that that restriction could effectively remove her from work because maybe the supervisor doesn't have any alternative tasks for her to perform. But if you say, don't lift, push, pull, or carry more than 5 pounds, well, maybe she can work with some smaller animals like little birds or little lizards. You see where I'm going with that? So this type of restriction will make it easier for her to do some form of light duty or light work while she's healing. All right. We have a 47-year-old female homicide detective who comes in after an MI or a heart attack. Cardiology has given restrictions that say no stress. And I love the cardiologists. We need the cardiologists. If I, God forbid, was to ever have some type of cardiovascular event, I would want to go see a good cardiologist. But while they are good at heart stuff, They're not always so good at work restrictions. How can a police officer have no stress? How can any of us, as mere mortal human beings, have no stress? So it's such a vague restriction, it's not that good. So I'm going to show you how to write that one a little bit better. So when someone has a heart attack, the anticipated timeline of recovery can vary based on your age, based on your baseline health status. So the range is 6 to 24 weeks, right? The issue in this particular case is that this detective is a homicide detective, specifically for pediatric cases. And so when viewing things like crime scene footage, pornographic material, child trafficking, autopsy pictures, all of that just increases the level of stress that this police officer experiences. Additionally, prepping for depositions, prepping for trials where you're going to be standing or sitting across from the person who's committed a heinous act, all of that is very stress inducing. So a better restriction for this particular police officer is to say no work with graphic images such as, and you give the examples, and don't participate in judiciary activities, right? So when I'm communicating to the supervisor is, hey, she can still come to work and I don't know, file papers. But in terms of the real gritty task that she has to do every single day, we want to avoid those. So hopefully that's clear. You can't just say no stress because that is life. Life is stress, good stress and bad stress. We need to be very specific on the specific tasks that we don't want the employee to participate in. Okay, here's another one. 27-year-old female ultrasound tech who comes in with an overuse injury to the right forearm, the right wrist, and the right shoulder. So she's diagnosed with strain for all of those body parts. And that type of injury should take anywhere from 1 to 12 weeks to recover from. So just give you a second to kind of think about what would be an appropriate restriction for somebody with strain of the right shoulder, forearm, and wrist. And in this case, the technician thinks her symptoms are due to applying excessive pressure when she's using the ultrasound probe. A lot of her patients are obese. And so to get through all the adipose tissue, she's having to press even more forcefully with the probe. And there's a lot of awkward positioning. Okay. So a good restriction would be maybe don't do ultrasound on patients with a BMI greater than 30. Now, I know most Americans are obese, so that might be a very difficult order to fill. Alternatively, you could write no use of the ultrasound probe with the right hand. So maybe she's ambidextrous and can use the left hand. But if you put something that says no use of the probe whatsoever, you could be effectively removing her from work if her supervisor has said, hey, this patient, this worker is not ambidextrous. I have nothing else for her to do outside of ultrasounding. So if you put no ultrasonography on patients with a BMI greater than 30, you're trying to remove what was actually causing her symptoms, which was the excessive force on obese patients. So if all of your patients are not obese, right, with a BMI less than 30, then theoretically you should not have to apply as much pressure when you're using the ultrasound probe, allowing the body parts to rest. Okay. All right, so we're going to transition a little bit. We did some case examples of, well, just writing a work restriction, but over time, as the person is healing, the work restrictions should be evolving. And so because the restrictions evolve, or you're gonna titrate them because the patient is healing, we're gonna go through an example of what that would look like. So you have a 48-year-old male, he's a car tech, and he comes in with right elbow pain after he falls at work. So you do your x-rays, you find that he's fractured the radial head, which is in the elbow. This type of injury can take anywhere from 4 to 10 weeks to heal. And so from the outset, you say, hey, don't use your right arm. We don't want you cranking wrenches. We don't want you taking off oil caps. Just don't use it. Okay. And so as he heals over these 4 to 10 weeks, we don't want to keep that same restriction in place because he's going to be healing. He's going to be getting better. He's not going to have as much pain. And so at some point, no use of the right arm is not going to make any sense. So when he comes in for follow-up 1 to 2 weeks later, and maybe his acute pain has subsided, it's okay to say, well, hey, now you can use that right arm, but I don't want you to lift, push, pull more than a pound. And I don't want you to do any forceful gripping. So no use of wrenches. If you need to carry a manila envelope from one part of the shop to the other, that's okay. If you need to carry a pair of keys, that's okay, right? So now we transitioned from don't use it at all, baby it, cradle it, to hey, you can start to use it, but in a very light way. When he comes back, in another 1 to 2 weeks, you might bump it from 1 pound to 5 pounds. Then when he comes in another 2 weeks, which at this point is 6 weeks from the date of injury, and remember we said it takes 4 to 10 weeks to heal, you're going to bump it from 5 pounds to 15 pounds. Now, this is all based on your clinical judgment because you're talking to him. You're asking him, well, how did you do with the 5 pounds? How did you do with the 1 pound? And at each follow-up, when he was saying, yeah, it was great, fine, I don't have any pain, it was good, you advance him a little bit more. So then when he comes in for his 8-week appointment and he's telling you the pain is completely gone, he's able to flex and extend his elbow with no issues, you can return him to full duty because we know it takes 4 to 10 weeks to heal. He's at week 8. More than likely, he's all healed up and ready to go. Okay, so you can see how over time you want to gradually wean off the restrictions and get them back to full duty. There are a lot of patients who come in and they have poor attendance to their appointments. Sometimes it's very innocent, maybe they forgot or something really important came up and they just couldn't make it and they actually called and rescheduled the appointment. We have no problem with that. But there's a lot of times where folks are missing the appointments and they have no valid reason. A possibility is they just want to ride out the restriction, right? So if you tell me no use of the right arm and my supervisor can't accommodate that, so I'm at my house doing whatever I want to do, maybe I'm not inspired to come back to the doctor and have that restriction removed. So I'm just going to miss my follow-up appointment. And so when patients, and there's not a lot of patients that do that, but there are some, there's enough that I'm bringing it up. If they are repeatedly missing their appointments, causing the restrictions to drag out, you can place preemptive restrictions with the dates that the restrictions are going to go into effect. So as an example, on the first visit, on February 20th, you'd say no use of the right arm. Now, he's supposed to come back and see you a week later on February 27th, but he no-shows. And then he's bumped to March 5th, but he also no-shows that appointment. And so now you're clued in that, hey, something is amiss. When he comes in on March 9th, you can go ahead and advance his restrictions to no lift, push, pull more than 20 pounds. Now, in this example, I'm moving away from that radial head fracture, and this could be something simple like a really bad sprain. Okay, so when he comes in on March 9th, you're going to go ahead and say, hey, I'm going to bump you up to 20 pounds, But because I know you're not really good at doing your follow-ups, I'm going to go ahead and say on March 16th, I want you to return to full duty. And the reason I'm doing that is so that even if you miss your follow-up with me on March 16th, it doesn't matter because HR and your supervisor already know that you're expected to go back to full duty on March 16th. So you're removing their opportunity to drag the restriction out just because they don't feel like coming to the appointments. And so it's a good strategy that encourages workers to keep their appointments, and it also reveals those who may not have a true injury. All right, so let's do a couple what ifs. Well, what if the worker doesn't like my restrictions, right? My question would be, well, did you start by explaining what the injury is, how it's treated? Did you explain how long the injury should take to recover from? And then did you pivot and talk about work restrictions as a means of recovery, right? So a lot of the patients that I see in clinic, I talk about how the work restrictions may very well interfere with their ability to go to work, which will interfere with their pay. And sometimes just that realization is enough to get them on board with, hey, let's do this as quickly as possible because I don't want to miss out on my full pay. But at the end of the day, the worker doesn't have to do what you recommend, right? This is a recommendation, it's not a law. But just keep in mind, we're not being paid to be their best friend and give them whatever they want. We are being paid to facilitate their recovery as quickly as possible. Okay. So if the patient says, well, I'm not going to do that, then all you need to do is document it and communicate it with the employer. Okay. Same thing for if they don't follow the restrictions. You just document it. And over time, as you're going through those clinical notes, the insurance company is going through the clinical notes, the patient is not aiding in their own recovery. And so that may be a clue that we need to go ahead and close this claim because perhaps the worker isn't really hurt because they're not following the restrictions. Okay. So what if the worker requests specific restrictions? So they come in, they say, my back hurts, I can't lift more than 10 pounds, I need a restriction for that. Well, step number one, what does their exam say? Do you see any objective evidence of an injury? Because all workers' comp patients come in with some level of pain. So we can't really use that as the determining factor as to whether or not we're going to give restrictions. Do you see objective proof that there is an injury? Where are you in the treatment course? If you're at the very beginning of the case and the person works in a warehouse, well, then okay, it's fine. It's appropriate to put in that type of work restriction for back pain. But if you've already gotten to week 8 of treatment and you've done NSAIDs, you've done physical therapy, you're going to have that conversation with the patient that I'm so sorry, I know you're still in pain, but it is time for us to move the restrictions along and advance you just a little bit. So that one, you just kind of have to stand tough. Now, what if the worker is scared of re-injury? Okay, so you want to educate them on proper ergonomics. And a lot of the patient visit is like reassurance and encouragement. It's almost like a type of programming where I'm telling you you're going to get better. And our words as providers are very powerful because in most instances, our patients trust us and we have their best interest in heart. Most of us do. So when you are talking to the patient and you're saying, you know what, I understand that you're scared that you're going to get hurt again. If I had your type of injury, I would be thinking the exact same thing. But you know what? Our bodies are so resilient. And now that you've had this injury, you actually know how to better move your body and how to carry yourself in such a way that you don't get injured again. So you could go over ergonomic principles with them, like what is an appropriate way to lift. A lot of my patients that are nurses, I encourage them to go get the Hoyer lift. right? They're like, oh, but the Hoyer lift, I work on the 12th floor and the Hoyer lift is on the 3rd floor. I said, well, you're going to have to be that nurse that says, oh, I want to help turn you over, but I need to go get the Hoyer lift. Give me a few minutes, right? Talk to your leadership team about getting a Hoyer lift on your floor. And a lot of times the patients are saying, but I don't want to inconvenience my teammates. And I say, but you're being inconvenienced by having to come to the doctor every week. You're being inconvenienced by having to go through all these hoops in the workers' compensation system. Nobody is sitting in this office with you as you're crying with me about your back pain. So let them be inconvenienced. Go get the Hoyer lift. So you kind of have these pep talks with the patient to say, hey, yes, there's a possibility that you could get hurt again in the future, but now that we know how to better move, that likelihood has dropped, and I think you're going to be able to go back to work and be just fine. So you want to have those types of encouraging talks. Now, if a person feels like they can't tolerate the work duties, and they come in a second, a third time, right? Well, then maybe we should have a conversation about permanent work restrictions. Maybe we should have a conversation about changing the type of work that you do, right? So back to the case of the nurse, your body is your money-making tool. And so you can't damage your tool and still expect to make money. So talking to them about, hey, this job is very physical. You've been in here 3 times. Maybe we should talk about doing a different form of nursing that does not involve you using your body as a tool. So maybe instead of bedside nursing, maybe it's time to transition over to something like case management, where you can still interact with patients, you can still help them, but you're more on the administrative side of things instead of the physical side of things. So those are also good conversations to have with patients. Okay, so I go in the book, I go through, well, what if the employer doesn't like my restrictions? What should I do? So if you haven't gotten your copy already, I encourage you to do that. And I want you guys to look at this. This is kind of, I don't know if sad is the right word. I'm not going to say sad. I'm going to say it is what it is. But I started my Ascend YouTube channel a while back. And right now I have 5 subscribers, which you know what? I am so grateful. I am so grateful for every single one of these 5. And I recognize that I have not been as intentional with YouTube as I should be. So what I am committing to doing is starting in October, the second, I think it was either the second Monday or the second Sunday of the month, I'm going to be putting out a new YouTube video going through a case and talking about what should we be doing in order to close the claim more effectively. And closing the claim doesn't mean rushing the patient along when they're truly not better, but it's about educating the patient on what to expect so that the claim can close in a reasonable time frame and they can get back to their normal life. It's a win for the patient and it's a win for the employer. So I do a lot of med legal work, I do consulting, and I see cases all the time where patients are being kept out of work for no good reason other than they're saying, I have a hangnail. And the providers are aiding and abetting in this because they genuinely don't know any better. So the idea behind the episodes that I'll be putting out is educational material to help bolster providers to know, okay, this is what we need to do for a hangnail. We don't need to take them off of work. So I would love it if you all could subscribe if you haven't already, because I recognize that some of you have. So I'm going to transition now to questions. And I did get a question from my dear friend, Dr. Lebo, who I've never met in person, but I just so appreciate you and Mark because you all are so supportive of me and what I'm trying to do. So it's so good to see you guys on the call today too. On the call tonight. So the question was, how do you deal with companies that do not make accommodations? So Dr. LeBeau is referring to the fact that a corporation or a company will have an injured worker, and the worker may be motivated to go back to work, but the company's reflexive answer is, we don't have light duty, and we're not going to accommodate you. We are not going to help you come back into the workforce. That is a conversation that I would start by calling the supervisor. And I've done this a couple of times where I've said, hey, Mr. Smith is telling me that you guys don't have light duty and that you're not going to accommodate his restrictions. And I was explaining to him that he will actually get better faster if he's doing some form of light duty. I just wanted to call and see if I could help you with brainstorming on some alternative tasks that he could do. You know, a lot of times there are a billion things that need to be done that never get done because we don't have the time or the manpower. Now is a perfect opportunity to get some of those tasks done. Do you have any of those that maybe over the last 6 months you've been wanting to get to, but you've never had the opportunity? Mr. Smith could really help with that and kind of see what the supervisor says. And then depending on your relationship with the company, it may be a conversation that needs to be elevated to maybe HR or the C-suite, because ultimately you can make a very strong business case for why not accommodating a worker is not a good idea. You lose so much more money because now you're paying lost time, lost wages. They may be deteriorating faster because they're not active, right? But if you can put together an effective return to work program where we do have light duty and we do accommodate our workers, now you're not having to pay out for lost time. They're still able to get their paycheck and you're still able to get the productivity that you hired the worker to give you in the first place. So that's kind of how I deal with companies who don't make accommodations is I start with the supervisor and kind of work my way up, hopefully landing with somebody who will actually listen and understands the business case, and really the overall employee wellness case. Because when the worker is sitting at home not doing anything by themselves, right, that is not good for their injury recovery. So if there's any other questions, I will take those. Let's see. Okay, I got some comments here. Okay, Mark says, what you've presented seems to focus on intentionally explicit and contextual instructions that to me, as a layperson, seem like common sense. It also seems like they're not being followed consistently. Is it because doctors lack training, don't take the necessary time, aren't given enough good info by work comp stakeholders? Mark, it's such an insightful question. I too think it is common sense. Um, but maybe I'm biased because I've been in the occupational vein for so long. So if I had to put myself in the feet of my internal medicine or family medicine practitioners who do see the majority of injured workers because there's not enough OC docs, I would say number one, it's a lack of training. And I can remember being in medical school on rotations, and my attendings did not know how to fill out disability paperwork. If a worker came in and said, hey, I work at Publix and my back hurts, I need restrictions, there was this huge hesitation on what to do because they felt like they were inserting themselves between the employee and their job. So it's definitely a lack of training. There's definitely a time constraint because to sit there and explain what the injury is, how it's caused, how it's treated, what it does mean, what it doesn't mean, right? Because I've had patients come in and say, well, I'm in so much pain, I must have cancer. So now I have to give a dissertation on why you do not have cancer. And then to go and explain light duty, work restrictions, what to tell their supervisor. All of that takes a lot of time. And a lot of providers, we are entrapped in this system where people think we can see a patient in 15 minutes. Now, I'm sorry, you can't go get the oil in your car changed in 15 minutes. So why do you think I can talk to a whole human being, do a complete and accurate history and physical, and write prescriptions and do explanations all in 15 minutes? So uh, it's definitely a systemic problem and aren't given enough good info by work comp stakeholders. Yeah, I think more of us, and Mark, I know you have a whole universe of curriculum and resources. And I think most practitioners don't even know that that type of library of work exists, right? Like the adjusters know, a lot of our risk managers may know, our HR partners may know, but I don't think a lot of the providers know who are not OC-doc folks, right? Like your typical internal medicine, family medicine, I don't think a lot of them know. And so it really falls on us to go to these organizations where they live and talk to them about, hey, we have these resources. You need to know about it because a lot of the patients that come in to see you, they're asking for work notes. They're asking for time off. They're asking you to do their FMLA. They're asking you to do their disability paperwork. And so the more equipped we can help the providers, I think that will go a long way. I really do. I really do. All right. Well, I know some of you had to hop on late, so I will be sending out a video recording of this so you can see the whole thing from the beginning. I really appreciate everyone who came tonight and was able to join live. And if there's ever anything that I can do, let me know. But until next time, we'll talk soon. Bye.